Okay,
We move to the next
Sharma,
session. Thank you very much. For the next session, I invite Dr. Parshvara, Dr. Kevur Patel, and Dr. Manjunath as moderator, and Dr. Hitesha, Dr. Pramesh Gayatane, and Dr. Himang Gandhi as chairperson. I would request the chairpersons to introduce both the speakers and the case, and then the video of the same, and then move to the debate.
Yeah, hello, Dr. Hemang. Dr. Vivek Wadhwa is a professor in Department of Cardiovascular Thoracic Surgery in UN Mehta Hospital. For me, now he is working in the Raipur in private hospital. Is very good. I have worked with him for a long time. He's very good in surgical hand with the all CABG and valvular, and even with the minimal invasive cardiovascular surgeries. So he's a very dynamic surgeon. He will give today on that minimal that pacemaker with minimal CABG. And second speaker is Dr. Shomu Bora. He is associate professor also in the UN Mehta Cardiology Institute. He is my colleague from the MBBS, so I know him very well. So I worked with him in the UN Mehta also, and is very good in the EP study as well as a good human being. He has a lot of publications and is an editor in IPEG, and he is the author of chapters in the various books of ECG and EP studies. Both speakers are very good and very dynamic, so we have a very good discussion for today's topic. So you can hand over to the one of speakers.
Hi, Dr. Hemang. Thank you so much.
Yeah.
Am I audible?
Yeah, audible.
So I would just switch on to my screen, and I think so. Is it visible?
Yeah, it's visible.
Yeah. First of all, I congratulate the team CardioCon for such a wonderful effort they have put in, and I especially thank Dr. Kamal Sharma for having me here. Thank you so much. So I'll straight away shoot on to my case. We have a 88-year-old lady with a degenerative complete heart block here, who is on hemodialysis with right upper AV fistula and an occluded left AV fistula. So scheduled for a permanent pacemaker. She also has a 100% Osteal LAD lesion with a good distal target. So we want to decide on a permanent pacing strategy. So before jumping on to my conclusion, I would like to know a few things like the symptomatic status of the patient, collaterals on the angio, LV function, associated other comorbidities if she has, her frailty score, and her functional status. So if she is asymptomatic and if the vessel is very well collateralized, I don't want to touch her. I would just refer her to Dr. Shomu to do whatever he wants to do with her, like whichever way he wants to deal with her CHB, because he best knows how to deal with her. But if it is not so, then definitely I would want to go ahead with MICAS, so minimally invasive coronary artery surgery, along with an epicardial pacemaker implantation. Why? Because I feel for an osteal lesion with a good distal target, MICS is a straightforward surgery with as good a result as open surgery with a single graft Lima to LAD. And especially in such older patients, I want to avoid sternotomy, because with an old age and renal failure, they might have healing issues, especially for the sternum. So it's a safe, simple procedure. And then when I'm going ahead with a Lima to LAD, the heart is right there in front of me. I just want to go ahead and put the epicardial leads. Anyways, even if I'm not, even if the patient doesn't have a coronary artery, even if the patient doesn't have a CHB, I'm going to put temporary leads for the postoperative period, which may be one the atrial lead and another the ventricular lead. So this procedure is going to happen. But if the patient has a CHB, I'll definitely put a permanent lead. then the procedure is cost effective, because leadless pacemaker, the other option we have, may cost fortune to the patient. It reduces the hospital stay because both the procedures are being done in one setting. The cabbage is being done along with the epicardial pacing, and in a patient, in a 88-year-old lady with CHB who has undergone cabbage, I want early mobilization and a faster recovery. I don't want to add another procedure of pacing at a later date. So I want to be job done in the one go. And transepicardial pacing, some may say that it has got higher threshold and the battery may last less and all that. But in a 88-year-old lady, I just don't want to go in for another procedure in the post-operative period. Considering transepicardial pacing to be an established procedure, I want to add it to the cabbage. Then why will I not go for leadless pacing? So as everybody says that all procedures do have their own complications. Why you want to add another procedure to it? Post cabbage, if the patient has some post cabbage, if you add another procedure to it, it may have complications and it will definitely add to the discomfort of the patient. You don't want to do it. Apart from cost, the complications, like I said, with leadless pacing, there might be pericardial effusions and cardiac tamponade due to cardiac perforation, and then rushing in the patient for another surgery. You don't want to do that. They might have another complications which may be trivial, but which will lead to immobilization of the patient in the post-operative period, and you don't want to do it, like the vascular complications or device dislodgement or device migration, thrombosis of the device or tricuspid valve injury. They may, the numbers may be small, but can become significant in a post-operative period. So I'll definitely use transepicardial pacing along with cabbage in this patient. But there are places where I will not use transepicardial pacing and refer the patient to Dr. Shomu, and those will be areas when the patient doesn't need cabbage, or if the patient has associated comorbidities and a high frailty score or a functional status that makes the patient a high-risk candidate for cabbage. So I rest my case here. I would like to share a few things regarding epicardial pacing, because we are surrounded by surgeons and we are surrounded by cardiologists, and usually they don't see epicardial pacing being performed. So epicardial pacing is a routine procedure for after every cardiac surgery, in which we place simple leads in the post-operative period, and they act like temporary pacing. But when the patient has CHP and we want to make place permanent pacemakers, so we place permanent leads, which, as you can see in the figure, are fixed by sutures on the myocardium of the heart. We choose the place on the heart where the R wave has a good 4 millivolt potential, which can be very well tested with a technician around you. They place the lead on the heart, we place the lead on the heart, and they check the potentials, and wherever we can find the R wave to be more than 4 millivolts, we go ahead and fix the leads on the myocardium, avoiding the places where the fat is visible, where the lead can directly touch the myocardium. We fix the leads on the atria and on the ventricle for dual chamber pacing. We tend to use bipolar leads, which are always better than the unipolar leads. And we test the impedance and the threshold of the leads, and any threshold of less than 2 millivolts is good enough for the pacing. Then we make a pocket for the generator, and the pocket can be made anywhere where you find good amount of subcutaneous fat, and a good pocket can be created so that the overlying skin heals nicely and there is no tension on the skin, and the pocket is very well cauterized, and so that there is no hematoma formation over the pocket, and all this can be done very safely. So I rest my case here, and now it is up to the opposing counsel, Dr. Shomu, to go ahead with it.
Yeah, thanks, Dr. Vivek. You'll have to stop your screen share before I start. Actually, you have.
I'll do that, sir.
Yeah, you have helped me give the debate very well, because you have already said that bypass is an option in only a few of patients. So before I start, I would like to thank Dr. Kamal Sharma and Cardiocon team for having invited me for the presentation. Respected chairpersons as moderator, if I'm audible very clearly, I should go ahead. Is it okay?
Yeah.
Yeah.
You are audible. Yeah.
And
you can go
the
ahead.
screen slide is seen well. Is it seen?
Not yet, sir.
Sorry?
Not yet.
No, Shomu, you need to share your screen. It's not visible.
Yeah. So, is it now seen well?
Yes.
Now seen, sir.
Okay. Okay. So we have this case and questions, as Dr. Vivek had already discussed. And it's very important that we need to know the activity levels, weight, comorbidities, and the family status, because the cost of the implantation and etc. would be very heavy. But it's very important that why are we doing an intervention? What is the cause of a CHB and what is the implication, clinical implication in an 88-year-old who has CRF and who is on dialysis? Also, why an angiography was done? Was it just as a diagnostic procedure, or was it because of symptoms or because of an MI? It's very important to know. And having a fistula in the right upper side means you have increased flow in the right venous system. So you'll not be able to take that as an option for doing a pacemaker. And having known that the left upper limb occluded fistula is there, we don't know whether the left subclavian vein is occluded also. So these are the questions that I would ask before I go ahead. So performing a pacemaker intervention, even at this age, 88, it doesn't mean that you have to perform in all. 88-year-old, and if the patient is ambulated and able to perform own activities with a reasonable heart rate of 50 to 60, I would not even want to do a pacemaker unless the patient has syncope, breathlessness, fatigue, pre-syncope, rates are very low, or the patient has ventricular arrhythmia and an unstable escape. So a pacemaker implantation only if these are there. And revascularization in an 88-year-old, first and foremost, symptom status. Unless the patient is functional class 3 or 4, I would not want to intervene except with medications. Also to know whether there is scar or not, if there is viability possible, because with a CHB, how will you check viability without only a echo is there? So other parameters like collaterals, other vessels are very important, and revascularization with PTC can be seen based on the lesion if possible, because everybody is doing LMCA interventions nowadays. So these are the clinical questions I'm going to ask. First, asymptomatic CHB low risk and CAD low risk, medical follow-up. Narrow complex, if it is there, heart rate is more than 40, no long pause, nothing to be done. Now, if you have a symptomatic CHB, and there are two things. If the left subclavian vein is occluded, you have to do a pacemaker. So venoplasty, and then do a single chamber from the left subclavian vein, or use other sites like femoral, hepatic, or jugular, or do a leadless pacemaker. Epicardial pacemaker just for this without a CABG, I would not be comfortable. If you have a left subclavian vein which is patent, then there is nothing asking. You just do a VVIR pacemaker from the left side. However, the problem is if the right side goes and you have to again go to the left side, or because you are using heparin again and again, a leadless pacemaker can be of choice in patients who afford. Now coming to symptomatic coronary artery disease patients, where patients would require intervention as well as pacemaker, think whether angioplasty is possible or not. And if angioplasty is possible, even LMCA stenting would not be bad. You can optimize medications, you can attempt PTCA. Only if this is not an alternative, then bypass plus epicardial pacemaker is there. And therefore, of the case that is given, only 20% would be actually referred for CABG. And of them, if you see, because of the age, female, family structure, 80% or 90% would not even agree for surgery if you offer them also. So what is remaining is these 4% patients who would be offered getting or get ready for surgery. And then the surgeon, after seeing the patient, would say, okay, let me ask whether I would be able to do from a renal point of view. Is the left subclavian artery proper and the lima is proper? Whether the healing would be good because the patient has renal issues, and whether I have a good hospital who will take care of it. So of that, again, 50% will go. So only 2% would be going for surgery. And therefore, no discussion is required generally. What is required? Only a pacemaker is required. Now, which type of pacemaker? So epicardial, I think Dr. Vivek has already told that there is a problem with epicardial leads, but I think 88-year-old, even if the lead fails over 5 to 10 years, it will be taken care of, and we can again go ahead with another if it is bypass is done. So epicardial pacing is definitely a choice if you are doing bypass. But what are the options now? If you're not doing a bypass because you don't have a upper limb vein to put in a lead. So pacing options, if you don't have a suitable subclavian vein, are either another access or leadless pacing. So we'll go one by one. You can see this example where both the veins are not there. So what do? So the first option, which may be technically a little bit demanding, would be to have a venoplasty. You dilate the area of block. It may be subclavian, it may be superior vena cava, and get an access, and then you deliver a lead from that and put in a pacemaker. A single chamber VVIR would be okay. The second option is put a lead from the femoral vein. Now, to get this long leads is a problem, and then the sterility in a femoral area becomes an issue, and the stability becomes an issue. So people have also tried this trans-hepatic venous approach, where they can take a hepatic vein, as Dr. Means we do clearly tips and all in our labs. So similarly, you can just go ahead and get a hepatic access, and then through that you put in a lead and put a pacemaker on the epigastrium. Maybe a simpler way would be to get this kind of thing transjugular if the jugular is patent, and go from the internal jugular route, but the lead will be tunneled a long way. So it may not be very good cosmetically, especially if the patient is thin. So then came these leadless pacemakers, and there are two currently in market and third in development. They're very small, the size of a coin. If you see, they are just 2 grams in weight, and they basically have a simple structure. If you see, it's a 1 unit without a lead. So if you're seeing this, there is a full unit which contains the battery, the circuit, telemetry, and the pacing electrode directly. And this is the sheath system that is given. So leadless pacemaker indications, you should know that when leads cannot be placed because of venous access problems, or there is local site disease. Where will you put if the local site skin is a problem, where there is post-surgical, post-radiotherapy, or there are AV fistulas, or there is an active inflammation or infection. In high-risk individuals who have AV block with atrial fibrillation and you require only a single chamber pacing, or patient who have AV block, now the leadless pacemaker have a VDD mode also. So both patients, you can consider this. It can be a patient preference because it's a simple procedure and nothing is there below the skin, and it can be because of many places operator preference also. So I'll just put this a very small video. So this is the delivery system. So you have to prepare the femoral site only, have a TPI from the left side. That it's a 23 French dilator and sheath is 26 French, so it's large. So you need to have a very good venous access. If it is very tortuous, you'll not be able to put this sheath. So it's a single system, preloaded system, everything comes. So this is seen without blood. You will not be able to see this. This is then seen on fluoroscopy. So now you have nothing else, and the same pacemaker can be interrogated by using the same programmers that we use. So there is sterile, so chest need not be sterile in these patients, but we do prepare the patient in case there is a tamponade. So this is how you need to do one by one on fluoroscopy. You take a venous angio, see whether it is well, the dilator is advanced, and then you deploy this device. At least 2 tines of the 4 tines should be there. And this is what you see on fluoroscopy. There is no lead. The whole pacemaker is within the cavity of the RV. So implantation successes have been good, 97%. It's very easy. The 16 minutes procedure, 28 overall introducer to outside time. Most of them do not require any repositioning, and the patient can be discharged the very next day. And this procedure time will decrease with experience. However, you should know the contraindications. If you have a mechanical tricuspid valve, though there are case reports in which they have done through a mechanical tricuspid valve also, and if you have an IVC filter which cannot be removed, or you have tortuous wave, the problem is morbid obesity. If the patient is very obese, you will not be able to interrogate or check. So such patients cannot be taken up unless you have a way to check whether these will be able to be interrogated. And if you need atrial pacing for any reason, right now atrial based pacing is not there. The advantages are less implantation time, immediate recovery, complications related to leads like taking a subclavian access like hemothorax, pneumothorax, lead fracture, insulation breaks are avoided. There is no pocket, and therefore infection, hematoma, and cosmesis is much better. Implantation time is less, and shoulder mobility is never restricted. Many patients come with a frozen shoulder post lead implantation of a routine pacemaker. However, the disadvantage of a leadless pacemaker is the cost is around 8 to 10 lakhs. Specialized equipment and training is required. You need a femoral access. And if there is a problem, then specialized procedure for extraction needs to be learned. You don't have a complete for ICD or CRT. And what happens when the battery goes out? So it's not unclear. In the pediatric population, it's not possible. So there are technically, it is much better, less complications overall. However, there is a steep learning curve, and one should know that before doing. So these are, as Dr. Vivek has already shown this slide, there are complications. However, the incidence is much less. So these are some examples that you would see how a device would look after some time. You can actually put 2 to 3 devices, even if the battery goes. The complication dreaded would be the device migrates, or there is a vegetation, or there is a AV fistula locally. So summarizing, for a patient, this is a 88-year-old for CAD, optimization of medical management or angioplasty instead of bypass. If there is only functional class 2 or 1, then pacemaker only should be done. Angioplasty or bypass should be avoided. Subclavian venous access is often preferred, but if it is unlikely, then leadless pacing can be considered. Leadless advantages in this patient would be that you use a VDD leadless pacemaker, you will have AV synchrony. The chances of infection in a renal dysfunction patient would be less. You can immediately start with dual antiplatelet. and hemodialysis can be done with blood thinners without the fear of a pocket hematoma. However, the disadvantage would be cost, femoral related issues, and chances of mild infection. So summary, leadless pacemakers, though costly, offer standard pacing with immediate return to normal activities, and that is the highlight of doing a leadless pacemaker, and the complication rates are less. However, you should be judicious in advising leadless pacemaker as well as epicardial pacing in such patients. Just because the patient had a CHB or patient had CAD, you want to intervene should not be the criteria. The patient's symptoms are of paramount importance, and clinical evaluation is a must before you decide whatever is required. Thank you.
Yeah, over to chairpersons.
Thank you, Dr. Somu.
I think very well spoken, both the speakers. I think we, in our setup, what Dr. Vadva was talking about, cost constraints, and what Dr. Shomu was mentioning. I mean, I discussed with Dr. Shomu, and he also said that he also has done only one. But I said, you are the only one who's done one. Nobody else in Gujarat has done any. So you should be the only one speaking about this, nobody else. So I think he was also accepting the whole concept. And then he said, we need to have a reason enough to be using micra, and I think he is very well justified and brought out the case, like you have no access for the upper limb, you can't access it, and then CABG or no CABG is a separate debate in itself, what Dr. Shomu has clearly mentioned. Dr. Hemang, you were saying something?
Yeah, Mitesh here.
Yeah, the same question someone has raised. If patient has a IVC filter or means some issue with that, we can use the jugular vein. I think someone has put up that to Somu, Dr. Somu.
Yeah, means if you for a leadless pacing to do from an internal jugular, you need to be very, very confident, because 26 French and the sheath and everything, so movement, everything going from the neck is very difficult. There is, I think, 2 case reports what they have done from, but these case reports actually are done in very high volume centers, and also you should understand that this patient has a AV fistula, and you have already a problem on the venous axis in the upper side. So if something happens to the SVC, then you are actually gone. So I would not go from superior. I would definitely want from the inferior, because the hardware is made for an inferior approach. Hardware is not made for a superior approach.
Yeah, good save. I have the experience of putting the jugular vein for a large cannula in case of MICS, minimal invasive cardiac surgery. We use a venous drainage through the jugular vein in some cases. And I myself put quite a lot of times. And initially it was difficult for me, but after that we have find it is very easy to put, and that is around large bore cannula around 14 or 16 size that we are using. So that's why I ask. But it's what your concern is truly true that. Anyone wants to ask question?
Yeah, Dr. Hitesh was asking.
Yeah, Dr. Samu, that was a nice presentation by you. And the thing is, the most important message is like the symptomatic status of the patient at this 88 years of age with CHB, and that needs to be evaluated, because the option of MICAS plus epicardial pacemaker goes on merits ground to a less suitable option. Leadless pacemaker with micra is only the valid option, even if the patient has a symptomatic angina. In fact, if patient has a low heart rate.
So if I think we had a wonderful session, if we have no more questions, then we can have move to the next session. Thank you very much. Thank you, chairpersons. Thank you, speakers.
Thank you very much.
Thank you. Bye-bye.
Thank you, sir. Thank you, Kamal sir, for inviting all of us. And it's a nice.
Thank you.